I request my panelists for this session, Dr. Samvit Nanda from the Department of Radiation Oncology, MPMMC Varanasi, Dr. Ashutosh from the Department of Radiation Oncology, Dr. Holis D'Souza, Dr. Mayur Mayank from the Department of Radiation Oncologist, Dr. Rachit Channa, Dr. Mridul Malhotra, Dr. Komal from Department of Head and Neck Surgery, MPMMC. Over to you, sir.
So we'll start. And so we have a surgeon there. So Komal, can you tell us what's the importance of surgery in oral cavity cancers? If you don't do surgery, what happens? If you do surgery, what happens? And let's take for this discussion T3, T4 resectable oral cavity cancers.
For oral cancers, upfront surgery is the standard of care. And T3, T4 advanced stage oral cancers, if surgery, with surgery, the survival rates are approximately 40-50%, and they go down severely with non-surgical modalities.
Ashutosh, you agree with T3, N1 oral cavity cancers, 5-year disease-free survival if you give radical CTRT?
It would depend. Definitely surgery would be the standard of care, and if I don't do surgery, my results will not be that good. So I have, in fact, I would say the results would fall by nearly 25 to 30% decrease in results, especially if you're saying oral tongue. Definitive CTRT, we will have its failure rates would come down to nearly 50%.
Okay, so this is the only randomized study which has been done in head and neck cancer, which had compared surgery to definitive CTRT. When you look at all sides, the surgery holds an upper hand, but when you look specifically at oral cavity, and this is what you see, the 5-year outcomes with surgery and adjuvant RT are the staggering around 65%. If you do definitive CTRT, they are less than 10 to 15%. And that's the importance of surgery in oral cavity cancers, especially for oral cavity. And if you have advances like T4 and all, when the bones are involved, then giving definitive CTRT here again is a big challenge. So Komal, I'll come back to you. So when you see a patient of oral cavity cancers, what are the things which you see and you say that this is resectable, and this is where I may not be able to resect this patient?
So broadly for oral cavity, I would like to divide it into buccoalveolar complex diseases and tongue cancers. For tongue, if the disease is extending into vallicula, or if there's deep extension till the hyoid, then I would not consider these patients for resectability, because for getting my margin of resection, I would have to enter into larynx. So it'll require minimum of a supraglottic laryngectomy. So if I compare the morbidity of the resection with the benefits of surgery, I think the risk-benefit ratio will fall towards not doing surgery. For buccoalveolar complex diseases, if there is significant skin involvement, if there is high ITF involvement, and these are the and high ITF involvement, these are the cases which we do not consider surgically resectable. These are considered to be borderline resectable.
So whenever we look at head and neck cancers, we would have a spectrum which is clearly resectable. There would be a spectrum which is clearly unresectable. Disease going up to the base of skull. Prevertebral fascia is involved. The carotid is completely encased. In between somewhere lies a shady area, I would say, which would have shades of both, which we would say as borderline resectable. And this does not exist only in India. This is a survey which was done by Crefett et al. And what he did is, for those extensive head and neck surgeons, he asked, when would you not do surgery? The red bar actually says you that when this involvement needs to be removed, they won't not do surgery. So if you require total glossectomy and supraglottic laryngectomy, as Komal pointed out, 93% said they would not do. If you require total glossectomy, again 93% said that they would not do. As you see, when it is simple resections, limited resection, most of them are ready to do, because you don't only want that resection needs to be done. That has to be a functional reconstruction also. That's one point. Second is, your resection needs to be margin negative also. And the third is that These are biologically aggressive disease. You don't want that you do such kind of extensive surgeries. The patient has cosmetic functional loss, and then the disease comes back. There was a those who do lung cancer would know the definition of futile surgery. New England Journal of Medicine, when PET scans were discovered and PET scan started picking up inoperable lung cancers, mets here and there, that time when the concept of futile surgery came, which says if the majority of a patient after a major surgery are going to fail within 1 year, then that procedure should be considered as a futile surgery. And if you look at these results, I'll show you further. When you do such gross resections, most of them would come as a futile surgery. Just to add to this point, do we get negative margin positive resections? Yes, we get. This is a series from Tata Memorial Center, and you could see that close and involved in T4 diseases, this is around 30% of the people. Now, when you do this surgery in centers which are not doing so much volume of oral cavity cancers, it is different. And the reason why I put the photo of Dr. Jatin Shah is because he keeps showing this slide. And it's very difficult for people, when I just quote it in figures, say that in Western world in T4, 45% are actually margin positive resections. So what I'm trying to point here is there are objective criteria, but there's a subjectivity of the surgeon also. The expertise of the surgeon also matters. We have very good surgeons in India. We get 10%, Tata rate is around 5% margin positive. You could see that in MSKCC, the margin positive rate is around 45%. I won't spend time on this because this has already been discussed by you. Now, let me come to Wallace. Wallace, you have worked here. If you give neoadjuvant chemotherapy in a borderline resectable, what are the kind of outcomes you are looking? Let's put the outcomes at 2 years, at 5 years, and at 10 years.
Overall survival maybe in the range of around 50%, 50 to 60 on a very positive scale. This is for oral cavity. I will say like the buccal mucosa, not for the tongue.
So these are the results, and this we presented in the last year ASCO. This is a randomized study of 496 patients. Half received DC regimen, docetaxel platinum, half received docetaxel platinum and 5FU regimen. I'm showing you in this slide the results of 5-year data. This is at present this is in review in one of the high impact journals. And what you could see is if post NACT, if you get surgery, the 5-year survivals are pretty high. If you don't get that surgery done, the 5-year survivals are less than a year. And just to put it way further, before we get going to point, if you get a pathological CR in the surgery, which happens in 10% of the times, you could see that 5-year results. I'm not showing you any retrospective data or anything because we all know retrospective data are with bias. This is from a randomized study. And this would be in public domain in 3 or 4 months from now. You could see that the kind of outcomes you get into these patients. Now just keep an idea of these outcomes in your mind because I'll show you the outcomes which come with radical definitive CTRT in these patients. This is the outcomes which you get if you give definitive CTRT in these patients, and you could see the outcomes, the figures, what are they? Now, do these outcomes go for years? This is another data which is going out from our group, and this has got submitted for this ASCO. This is a retrospective database. This is a database of, you could see the numbers below, of 3,000, around 3,200 plus patients. And this is done by our student, Dr. Aditya Dhanawat, and he will be presenting this data this year. And what you are seeing here is, at the end of 10 years, you could see that a good number of people are doing well. Please go back to the Iyer et al. Paper where we saw resectable oral cavity cancer given definitive CTRT. We're talking about 10 to 15 disease-free % survival at 5 years. Now, let me put these outcomes in perspective and then we can move to the panel. These are the outcomes of T1, T2, N0, M0 from Dr. DeCruz's paper. And you could see that at 24 months survival is 80%, 60 months survival is around 70%. These are the outcomes of T3, T4, N2 patients from the OCAT study. And you could see that the 5-year outcomes, if you give only RT post-surgery, is around 25%. If you use CTRT, it is around 40%. So you could see that T1, T2, 5-year was around 60-70%. It dropped T3, T4, and to around 40%. Now I'm showing you the outcomes if you try to do surgery in such cases, and unfortunately, most of these papers don't get published, but this was presented in one of the FHNO conferences, and it's a big data from Dr. Desai. And this was abstract ID 115, and this was a huge data set of around 100 plus patients. I want you to focus, all these patients underwent upfront surgery. These were borderline resectables according to the criteria which Komal described. I want you to focus at the last column, average time to recurrence. You won't see a figure of more than 6 months. This is exactly the point I was making, that when you do surgeries in such extensive kind of diseases, most of the patients do fail, and they would fail within 6 months. This is our own data, because when we started, there were radiation oncologists who said, we can try radical CTRT in this. You could see that the axis ends at 12 months and not at years. The median survival of these patients was 6 months. This is same data which got presented at this ISMPO from the Chennai centers, from the Madras Medical College, and both the Cancer Institute ADR. Their outcomes also, both of these papers are in the review, are in the range of around 6 to 7 months. So let me come to the panel, and I'd like to have an opinion from all panelists, and we can start from this end today. Do you see all the patients in your centers in a multidisciplinary clinic where a radiation surgeon and a medical oncologist sit together and takes this kind of decision, or it's a decision which is not taken in that way? Because these decisions will require a multidisciplinary approach.
Normally, we try to do it, but it's not possible for all the patients to discuss with all of them on board. So.
Sir, I'm a community oncologist, so I don't have the luxury of an MDT. Most of my patients are either seen first by me or referred by a head and neck surgeon. So upfront, if they are operable, they usually don't come to me.
Okay.
So in our center, it is a routine that all patients are discussed in MDT, and then the call is taken on the modality of choice.
Here in TMH Varanasi, we also try to make sure that all the patients are seen in the multidisciplinary clinic once the decision is taken, then we go ahead.
Same thing, yeah, Rajat.
So it's not very difficult for me if the patient is not paying from his or her pocket, then DCF. If the patient is paying from her or his pocket, then it is dosis.
Okay, great.
So at our place, it's Akhil is there. So we have the DCF only. We admit them and have DCF
Okay,
if they can tolerate it.
okay. So DCF, Vidal?
So naturally, we need better responses. We need to have the idea is to get the disease operable. So a 3-drug is a preference if the patient is fit. If the patient is fit enough in terms of.
If the patient is not fit, let's say that these patients have an extensive disease, they may have a large tumor, the nutrition may not be that great, and the PS may be PS2 also. That is not an uncommon situation. Then.
So I would give 2-drug over 3-drug if I feel the patient would not tolerate the.
Then weekly Patil carbo is also an option.
Okay.
Sir, I have 4 options. One is TPF, second is DCS, sir, I said. Weekly Paclitaxel, weekly Patil carbo, plus or minus erlotinib. The fourth is what I've learned from Dr. Banavli is OMCT. Borderline patients. There's definitely a 5th coming up, but I have not yet tried that.
Okay, you use the
So
5-drug
for-
regimen of Patil carbo and OMCT. Okay.
I would like to add to that. So if they are borderline palliative, little more
Correct,
than
correct,
unresectable,
correct.
then we go on to OMCT.
Okay.
So that's the spectrum. DCF, then Patil carbo, and then OMCT.
Okay. Okay. Yeah, yeah. So this is the way we used to do it. We used to, as everyone told, it's all about the fitness of this patient. DCF is a pretty toxic regimen. Be prepared for 70-80% of grade 3 or 4 adverse events. So the patient has to be absolutely fit. This is the way we used to do in geriatric patient. We take into account the comorbidities of the patient, take into account the performance of the patient, and then plan it. Now, we talked a lot about 2 versus 3 drugs. We have data from the tax 323 and 324, which talk that 3 drugs was better than 2 drugs, but the 2 drugs here were cisplatin 5FU, and the 3 drugs was TPF. Not many in India practice cisplatin 5FU. Most of the choice of is actually taxane and platinum. And we had retrospective series which said that probably TPF would be better than taxane and platinum. And this, here we presented this data. Again, this was from the same study of 496. The primary question was whether TPF is better than TP regimen. And we could see here that yes, for the progression-free survival and overall survival, I won't say a big benefit, a modest to minimal kind of benefit, seems that the TPF is better than the PF, better than the TP regimen in terms of this. And this is what Akhil was putting into it. I don't see Lakhan here. Lakhan actually, in the COVID time, we started giving triple metronomic due to his patients because the daycares and beds were got occupied. And the triple metronomic went on, and then we added paclitaxel and carboplatin to these patients. And to our surprises, we saw here responses which were upwards of 60%. So the initial 14 patient series got published in Cancer Medicine. We presented a series of 72 patients. And in fact, if I believe Akhil is running a randomized trial on this, comparing this with the TPF regimen to see whether this can replace the TPF regimen. I won't say that it doesn't give side effects, but it doesn't give life-threatening or fatal side effects. It gives those side effects like fatigue, rash, increments or decrements in LFTs which are been seen. Next question, and we'll start with Hollis. How many of you do DYPD mutation before giving 5FU?
I don't know anyone now. Currently, why? Because it takes at least 4 to 5 days for the therapy to start. And if the patient is willing to wait, then only go ahead with, because I have to act on the result. If it is a heterozygous, I have to convince them that I cannot be using 5FU. So what I am currently doing is 75 to 80% of the dose of 5FU for those patients who are going to go for the DYPD mutation.
So I'll go one step backwards. What is the dose of 5FU you use in your TPF regimen?
750.
750?
Yeah,
Day 1 to day 5?
Day 1 to day 5.
Day 5.
I don't compromise on day 1 to day 4 or day 1 to day 3.
Okay. Vidul?
So the DPYD is to be done in all patients unless there is some logistic reason of not doing it. And if definitely there is a toxicity, then definitely.
How many mutations you have seen in, let's say, last 1 year?
So I've not given actually to many patients, to be very frank.
Rajat?
So I don't do it because I think in GI malignancies, FOLFOX, FOLFIRI, it is very commonly used, and I have not seen any reason to do this mutation before starting for head and neck patients. So I don't do it.
Okay. But if you have never landed with gross diarrhea or anything?
No, I don't give, if I plan to give DCF, I don't give it for 5 days. I give it for 3 or 4 days based on
So
patient.
you already give like 60% or 50%?
Yes,
dose.
because the toxicity comes with a lot of cost. So it's you can compromise maybe on response rate, but not on finances. So that's a thing that I've learned.
Yes, sir.
Vijay, it's very interesting. And I would like to know somebody who is doing regularly, because in between I started doing it regularly after, all these
Yeah.
talks. And I think I did 35 patients, not a single patient abnormal report. Then I stopped doing it. When I look back at last 18, 19 years, I don't recollect a single patient where I have lost mortality because of 5FU induced GI toxicity or neutropenia. So I just want to know that, is this a theoretical discussion or is really in practice it exists? No, not the literature. I want to know the people.
Sir, I'll tell you. So there are 2-3 reasons that I'll give you. If you look at the pharmacological consortium guideline for DYPD mutation dosing, in India there are good papers from Orissa, Ahmedabad, and if I'm not mistaken, from Uttarakhand also. Already people are not using the recommended dose of 5FU, that is of 750 milligram per meter square from day 1 to day 5. People have already started doing dose reductions of 70% or 60%. Even if you get a heterozygous mutation, that heterozygous mutation, most of the time the pharmacological guideline will actually tell you to do that dose reduction. We are already doing dose reduction for all 100% patients. And the second is, this, according to me, would change according to ethnicity. I have worked in Kerala. given DCF in them, side effects were very minimal in Kerala. Side effects were very high in when we used to look at Tata. Tata, we used to do it routinely for all patients. And I'm not talking about 100 patients or 200 patients. The series from Tata is around 1,200 consecutive patients. And we got a rate of around 28%. And I agree with what Rajat said. Many people have already reduced the dose. If you're going to give a reduced dose of 5FU, you actually don't have to do a mutation because you have already decreased the dose.
I get in heterozygous, but in
Yeah.
a homozygous, any dose of IFU can be lethal.
Sir,
right?
I agree. Homozygous is 1%.
Right. Second thing is like even in Tata Hospital or even in Max or even at Hope, 750 is the bare minimum which I give. Normally I follow day 2 to day 5, 1 gram per meter square. Okay, in DCF. Folfox in adjuvant setting, you don't reduce the dose. Folfiri, you don't reduce the dose unless and until you have a patient whom you really think this patient is not. My question is that assuming it is heterozygous,
Yeah.
30%, let's take a figure of 25%,
Yeah.
1/4 of the patient. All the panelists sitting here and everybody here, I don't think that we would not have treated less than 100 patients of 5FU. That means 25 patients should have at least grade 3, grade 4
Correct.
toxicity.
Correct.
And we don't see that type. My question is,
I would say that you are lucky, sir.
no,
Okay, when I give
luck
TPF,
does not happen for
no, no.
last so many years.
Dr. Vola, let me be clear here. In the randomized study, in my routine practice, I would ask Akhil here, we see horrendous side effects with Dr. Sir, you see side effects with TPF or?
Vijay,
Yeah.
could I add to that a little
Yeah.
bit? So I have worked in Punjab and in Tamil Nadu,
Yeah.
at Jipmer and in Punjab. When I have seen that in Punjab, the patients could tolerate full doses of 5FU, but in Tamil Nadu, they would be dehydrated, sir. And their tolerance was much lower. After the first cycle, we had to reduce doses. Up to nearly 20% dose reduction.
It becomes more than Folfox 4. So my question is that, is this a theoretical exercise? Yes, Vijay, you, Akhil, you also work with the patients who are nutritionally poor. So have we taken that factor? Because somebody who is nutritionally poor, who's not able to eat, you definitely will have.
If a patient is nutritionally poor and is not able to eat, he won't be given TPF.
Correct, absolutely. So
He
the
would be
question
given
is, in a
food drug reaction.
heterozygous patient,
Yeah.
I think cytopenia also is one of the major side effects if there is a DYPD deficiency.
I agree
Okay.
with you, sir. In fact,
How much of cytopenia
let
is
me
in Folfox,
put-
Folfiri we see?
Sir, let me put it other way around. And where if you see the literature for DYPD mutation, colon cancer DYPD mutation rates always have been low, even from India. It is specifically in head and neck cancers. I don't know whether there's a relation or not. It has been, which have been said that it may be high. The second is, if you see the Lancet publication we came in 2019, it clearly says that every DYPD mutation, you may not get side effects. Second, every DYPD mutation, you are not going to get diarrhea. The DYPD mutations, few are specifically related to neutropenia. A few are specifically related to diarrhea. In fact, we actually went and tried to find out. The way we identified is by this way. For our 32 patients, when we saw these 12 patients got severe mucositis, we retrospectively went and saw that why was the mucositis there? And all of this, let me tell you, this was done in Ranbaxy. Then so all of these were deluxe patients of Tata, not even of general class patients only. And in that we saw this heterozygous. And let me tell you, at that time, this test used to cost some 15 or 16,000. To give a 15 or 16,000 test to a patient used to be very difficult. We actually, I don't know whether Dr. Anuradha is here. We actually made this test in Tata and made it at the cost around 2 or 3,000 so that every patient could get it done. And that is the way we did it. Yeah.
Sir, may I add, sir?
Yeah.
Sir, the lot regimen that I believe was supposed to be very toxic, that is almost easy to handle, but DCF in head neck cancer becomes difficult. I think the problem is because of the location of the tumor. As soon as the patient develops some side effects, the nutrition decreases drastically. So I think that is also an important factor apart from the
but- yeah,
mutation.
but
So, you know,
what-
if we start with a lower dose, then that becomes very comfortable. So I don't think that we should give it for 5 days with a full dose. 4 days is good enough with a better tolerability. And I don't know whether
Yeah.
mutation
So,
plays a really.
Rajat, I won't agree with that, that we decrease the dose to 4
Sir,
days
आप तो
because-
low dose वाले ही हो.
But low dose देने के लिए rational भी होना चाहिए ना. If we keep continuing doing 4 doses, 4th day or 3rd day, we are actually giving suboptimal dose of IFU. We actually don't know whether it works or it doesn't work. And if you see in that's the reason I showed the TPF versus TP curves. The benefit of IFU is not very big. It's pretty, I would say, modest at the most. So rather than giving low doses, we can actually think about omitting the.
Yes, and
Yeah.
I think,
Yeah.
and that gives, I've given it in few patients and almost all of them underwent surgery, 2-drug regimen.
Bharat, you had wanted to ask something.
See, we, in the past, we never did this test. And we used to reduce the dose at most of this, because in private practice, you can't afford to have so much of toxicity. Those patients who showed the toxicity which we are describing here, mucositis and severe myelosuppression, we tried doing that. We ideally should not do that after the toxicity develops. But there is no correlation that patient had severe toxicity and the DPD came positive. Then, as you rightly said, there are tests which are not clinically relevant. Most of the time, 60% of the time, the report came positive, but the line came that no, this is not a clinically relevant good.
And you lost the patient. So I won't agree with the 20% reduction. I think we need to give the doses in the strength if the patient is fit in the way they have been described, because we don't know what that 20% or 30% reduction is doing for the patient.
So I probably just add to both, I think Amish and Vijay, what were being discussed. Usually we do not do routinely in our clinical practice, that is number one. In my understanding, if you are ordering a test, probably you should not start patient on 5FU, because unless you get a report, you should not start a report. Coming to ethnicity and the nutritional status, we have 2 facilities in Delhi NCR, one is at IRCH Ames, where we hardly are using TPF. We use always most of the time to the combination, because they are usual patient who comes there by chance or by virtue of that they are nutritionally deprived. We do not use. Another facility at NCI, most of the time we end up using 3-drug combination and they tolerate well. So the complication is part of, we don't see so much of the side effects in this thing, GI and float and this thing. But head and neck TPF usually in my personal experience and see a lot of side effects.
Sir, may I add? Sir, 3 patients which I saw at Homeopathic Cancer Hospital when I was in Varanasi, that we gave 3 days only because of nutrition deficiency which a patient were having, and we could notice the PAT-CR after surgery. So I think yes, it is not documented, but sometimes we can do this modification. DPD we don't do usually. I mean, I think.
But that cannot give Anuj a conclusion that if you would have given TP
That's
versus the TP plus suboptimal dose of that patient won't have developed PAT-CR with TP itself.
no, it's
So
not that.
what I'm trying to tell you is that unless we have, we all do individualization. As Dr. Ora himself said, he gives it from day 2 to day 5. So he already does a 20% dose reduction. Huh? Okay, so you are giving 1 gram the meter square. So he's giving the vein regimen. Yeah, he's giving the vein regimen. So what I'm trying to tell you is that when we do this kind of dose reduction, which can be done for patients if they are like nutritionally poor or ill, but for a fit patient to give a suboptimal dosing may not be the way what we want to tell to the younger generation that nahi suboptimal dosing kar dete hai.
Sir, sorry to interrupt.
Yeah.
One doubt, sir.
Ah.
Sir, sometimes for a resectable oral cancer, the patient may be referred for neoadjuvant therapy just because the waiting list is like 2 or 3 weeks or 4 weeks. So in that situation, would you want to give some therapy, OMCT or chemo, or just observe?
So
Wait.
take that question with respect to, there was a study done by Dr. Sudhir Nayak. It was a study of 64 patients. 16, 16, 16 in 4 arms. One arm, the waiting list for surgery was of 4 weeks at that time. So one arm, the patient waited for 4 weeks. One arm, they got only erlotinib. One arm, they only got celecoxib. One arm, they got erlotinib and celecoxib. The patients who waited had 65% had progression of disease. See, the thing is, the kind of operable we get is many times a T3, T4, which you wait for 1 month, you actually end up losing that window. When we give erlotinib and celecoxib, the progressive disease dropped to 5% only. This is a randomized study. This was a phase 2 study. That clearly shows that no, if there is a long waiting list, you need to give something to the patient. Now, what that something would be better, that would depend upon what your institutional policy is. It may be TPF, but I'll tell you many times TPF, the patient has to be fit. Erlotinib celecoxib also gives you good amount of response rate. To be very frank, if you look at the Dr. Ravi Upalli's data of giving immunotherapy single doses, 2 doses of immunotherapy, and there is not one, there are now 7 prospective phase 2 studies, both by the Vijay group from Dr. Ravi Upalli and the German group of pembrolizumab or nivolumab, that you give 2 doses and you get a pathological major response rate of 45 to 59%, which, and immunotherapy we all know it's tolerated very well. The data from Tata, which again will be presented this ASCO, shows that 87% of oral cavity cancers in our subgroups are PDL1 positive or more, and around 60% are PDL1 50% or more positive. So I think the choice would depend upon your institute's policy of whether you want to give metronomic DCF or want to give immunotherapy. Like for their one, we routinely used to give metronomic only. Whether this metronomic would lead to improvement in outcomes of the patient, that question would be answered by Dr. Pai's study, which is a 300 plus patient study, in which one arm of the patient's operable had received surgery, followed by appropriate adjuvant, which is RT or CTRT. Other arm has received in the waiting period neoadjuvant metronomic, completion of CTRT, and then metronomic of 18 months. So we have to wait for those results to come, whether this is better than this. But if the patient has to wait, according to Dr. Nayar's data, a good amount of patients do progress in the waiting period in the time span of only 28 days. Yes.
Sorry, one question. Although there is no clear-cut guideline, see, NSCT is also majority of the time is something India specific. The guidelines still have not incorporated NSCT as any of the category.
So which guidelines are you talking about?
NCCN guidelines,
So
ESMO
NCCN
guidelines.
frankly, sir, give an option of NSCT in hypopharyngeal cancer, which is actually placed above CTRT.
No, I'm not debating.
No, I'm telling you that the NSCT is there in, in guidelines.
Many patients are able to undergo surgery because of NSCT. I'm sold on that.
Yeah.
My question is, if the patient, if we end up doing PDL1 and if the PDL1 is 80%, do we add immunotherapy in NSCT setting today? As of today, 2023, do we add in with a full medical legal cover? And I would like to ask all the panelists and Vijay, you, because our buck stops at you and Kumar for all head and neck tumors.
So I'll tell you, at present, if the patient is borderline resectable and this is above 80%, I would still go with TPF regimen at present. That would be my answer. Unless if the patient is not fit, if the patient is not fit, that I would take a written informed consent that because you are not fit, I am giving you an immunotherapy based regimen. That is what I would do. Let me ask the panelist.
So definitely, I totally agree with you on this.
Alice?
That was the start of that I thought using.
Yeah, just a second. Rajit, what would you do? देखो पेशेंट डॉक्टर ओला से तुम्हारे पास भी आ सकता है ओपिनियन के लिए.
मैं तो दूंगा सर.
He is very clear.
So I would explain that this is the best possible regimen that we have in a metastatic setting, and probably you won't be a candidate for surgery. So I'll label this patient as potentially resectable and potentially curative intent, and I'll explain it and I'll give it 80% PDL1. There is a chance, but I'll give it in as a combination.
His question is, sir, if the PDL1 was 80%,
NSCT,
In NSCT.
borderline resectable,
Borderline
we decided to give NSCT. Biopsy showed PDL1 80%. You have decided TPS.
So-
Do you add? Pembrolizumab, for example.
I have a patient
Sir.
who has a second primary.
okay.
So he was referred to me for NSCT and surgeon was not sure whether he will take up for surgery. So I gave him this combination same. His PDL1 was around 15%. He had CR after 3 cycles. So patient did not undergo surgery. Patient is also happy.
Sir, I suggest we should not go by anecdotal evidences. And in such a scenario, if the
Yeah.
immunotherapy has to be introduced, it has to be on a trial basis, on a trial setting. Yeah, that should be the approach.
Swarati?
Yes, sir. So in my limited clinical practice, I encountered a patient who was borderline resectable. His PDL1 was 2% or 3% high, but he was unfit for DCF. So I did review the literature. There's an ASCO, I think 2020 phase 2 data for Patil, Carbo and Nivolumab.
That's what.
It had like a PR rate of 40%, partial response rates of 40%. It's not a bad option. We have some data. The full paper has not been, is not published yet, but we do have.
I agree with you. That's what I said. If the patient is fit, TPF, if not fit, then you explain and give it. I have neither I have any experience, neither I am aware of any evidence. In fact, you should give your opinion on this by publishing that data, because I can't opine on that. I think they would have responded equally well to probably weekly Patil cargo. So so if you give TPF, I will start with this side for Rajat. Rajat, what precautions you take?
Sir, as you described in your slide, that nutrition becomes very important. So if the patient should be absolutely fit in terms of nutritional status, cardiac functions, kidney functions, and patient should preferably stay nearby. In case they develop some complications, they should be able to come back, or they are ready to stay for the hospital for at least 7 to 8 days. So basically patient should fit all the criteria for fitness, and in terms of finances also patient should be ready to shed out money if they develop complication.
So what is the kind of money you?
Sir,
put
around
for one cycle?
if the patient requires, I see chemotherapy only will cost around 70 to 80 per cycle. If the patient requires ICU admission, that will range from 60 to 1 lakh per day, ward admission 20 to 30,000 per day.
So that will be 3 lakhs or 4 lakhs per cycle.
Yes, so, and the problem is that, sir, the patients mostly have insurance of 5 lakhs, so they need surgery, radiation and all that.
Okay.
So you need to see all that. So I know this is the practical point that you should consider before.
I agree. Vidul?
So you can give 5FU even through the pump, not just admit the patient for 5 days. So that can considerably reduce the cost of chemotherapy. That is one thing. Obviously, it is a toxic drug. It's not that we can admit the patient for 10 days and, keep him under observation and give chemotherapy. So keeping the finances part aside, I think we have to look for the renal functions. We have to look for the audiometry, cardiac functions, and explain the patients all the side effects and keep the nutrition high even when the patient will have toxicities. Low threshold to use painkillers, morphine whenever the patient will have mucositis, because that can hamper the nutrition. A low threshold to put the Riles tube and to use the TPN. So I think this is what we have been trained into and we are practicing now.
Alice?
Regarding the logistics for TPF.
Any, how do you give TPF in your practice?
So the thing is, first starts with PICC. So the cost escalates there. Putting a PICC is 20,000 minimum. Preferably in a cath lab, 30, 40,000, then the medicines, then the day charges, then the toxicity, then the tests. So I'm fortunate enough to have my own setup, so I can cut down on the costs a lot. No PICC, I tried for peripheral vein. I burned my fingers on that, but that is what community practices. If I'm in a luxury setup, definitely a PICC, DYPD might not act on it, so might not do it. And as Rajesh sir has said, yeah, finances for the medicine and also for the toxicity. If not for toxicity, not staying nearby,
No, day.
Two drug.
Two drug. Ah, yes. Sir.
Because it's very interesting. How I give TPF, I have not admitted a single patient of TPF in 24/7 facility. PIC line is a must. And I sincerely with folded hand, because I have burnt my finger so many times with peripheral vein. Patient request karta hai, sir, de do na, hum dhyan rakhenge. Do not fall for that prey. PIC line is a must. And that is what I have learned out of my experience. First day, you give Texane, cisplatin, hydration. If you want to divide cisplatin into 2 days, you can divide, but otherwise follow the regimen properly. Second day, you give hydration and 5-FU in the pump for 2 days. Then, third or fourth day, again, you call the patient for hydration and you give the pump again. By this regimen, even in South Delhi, remove PIC line, because PIC line is a one-time cost. I am able to give TPF in 35 to 40,000 rupees. These are my billings, okay? This is what able to do that. 5FU का cost क्या है? Texane का 2 बार की daycare charges होता है खाली, twice. That's all. And 5FU का cost क्या है? Pump, of course, is there.
बता रहा हूँ मैं, वरना टाटा के भी पेशेंट आपके पास आ जाते, टाटा में भी हमें 45,000 हो जाता है.
This is how, and Vijay, as you said, in mask, I have sent a paper. One thing which I have learned, we have a personalized, dedicated onco-nutrition.
Okay.
So I have sent a paper. Let's see whether it gets accepted or not. We follow each and every side effect for diet plan. The diet plan gets revised at least 14 to 15 times. And we have seen the weight reduction of 8% in TPF. No, I think let's give 3 minutes here. मतलब हमारे panel से 3 minute काट देना.
So the thing what I wanted to say is that whichever you want to practice, make sure that these patients get good amount of side effects. And this is what I was trying to show you, is that Tata says around 20% of them get febrile neutropenia. And as Bharat pointed out correctly, hyponatremia has not been described in literature to be associated with this regimen, but this regimen gives a good amount of grade 3 or 4 hyponatremia. And what Dr. Vora also pointed out is correct. If you look at the drops which happen, these drops most of the times happen anywhere between 5th to 10th day. So if you are giving TPF to these patients, you need to monitor them very closely, because this is the day when things will go haywire with respect to this patients. And if you don't follow this, and this is from US, and because we always like to quote NCC, and that's why I showed it as the US, is a mortality of 15.3% in US centers. So this is the reason why we need to be careful when we are giving DCF. And this is about the alternate regimen. I'll just stop here, because I think we would shoot off time, and just show that we have a whole lot of data from India now. And these are all publications from India, which are on neoadjuvant chemotherapy in technically unresectable cancers. And this slide is 2 years old. We would have more now. This has got adopted in many of the guidelines, and I kept that name specifically of Dr. Varmorkan. This has got adopted as a topic in completely, which he credits completely to Indian development in induction chemotherapy in borderline resectable oral cavity cancers. And this has got adapted. This is an ASCO guideline, and this has got adopted in the ASCO guideline for low and middle income countries, especially where you have that oral cancer technically unresectable needs to be kept as one of the treatment options. With that, I would say thank you to all panelists, and I would say thank you to all audience. It was a great. Chalo, yeah. सर वो उधर है रिकरेंट मेटास्टैटिक केस में
Unresectable, not.
सर आपको मैं स्लाइड भेज दूंगा. पैगन का पेपर है, JCO में है सर. Paper is there in JCO. So if there are any questions, we can take 1 or 2 questions.
I have one.
So if you are talking about cisplatin 5FU has 2 drugs versus TPF has 3 drugs, we have 2 trials. If you are talking about Taxane and platinum versus taxane, platinum 5-FU. We presented a randomized study of 496 patients in the ASCO of 2022. It got overshadowed by the docetaxel and low dose immunotherapy. And you would see this in public domain in around 4 to 5 months by now. It is showing a modest OS benefit. So I think we discussed that. We missed you. Actually. Yeah. Bolo, yes.
Sir, the Iyer et al. Study which you have quoted. So surgery is superior to chemo radiation in stage 3, stage 4.
No, the overall conclusion is in advanced head and neck cancers, surgery and definitive CTID had similar outcomes. It was specifically in the oral cavity and the maxilla subgroup where they saw that 60% versus 5% in maxilla, 60 versus 15%.
Subgroup had only 30 patients.
Correct.
Only 30 patients.
Correct.
But how did
So fantastic question. You need to ask this to surgeon how surgery became the standard of care in head and neck cancer, not a single randomized study, no evidence at all. But we accept it.
So, suppose we are giving induction chemotherapy and taking for surgery versus giving chemo radiation, and if the patient has residual disease and we take up for surgery.
Yeah.
So why do you think here going for radical CTID upfront will be giving a poor outcome in such?
So radical CTID upfront, the outcomes which I showed you from Tata, I've seen outcomes from Madras Medical College and ADR, and outcomes are there also from RCT Trivandrum, which practices this. All have shown a median OS of around 6 months. See, I'll tell you, the surgeons don't do we are lucky in our country to have fantastic head and neck surgeons. As I told you, MSKCC has margin positive rate of 50%. Most of our institutes will have margin positive rate of 10% or more. When you say that the disease is big, this is up to the zygoma, going up to the bone, this is at least 10 to 12 centimeters. This extension will be at least 8 centimeters. There will be lymph nodes. To cover that amount of gross total volume and give definitive curative radiation, Ashutosh would be better to explain you that if you have this node involvement is huge, bone involvement, very difficult for you to get complete. The other approach which you are telling that we give NACT RT, like neoadjuvant CT-RT and then try for surgery, has also been tried in phase 2 studies and has also shown how to have good results. But I'm not very sure how many head and neck surgeons after this NACT RT would be comfortable resecting it and again doing an functional reconstruction.
Dehiscence is the problem.
Yeah.
Definitely is the problem. And also one thing from the radiation oncologist point of view is neoadjuvant radiation per se.
Yeah.
That means a lot of necrotic tissue, deoxygenated tissue, and therefore radiation may not be that effective at conventional fraction. So 1.8 to 2 gray radiation may not be that good. So I would prefer to give in chemotherapy first, decrease the bulk, then go in for definitive therapy, either surgery or if not possible, definitive chemo radiation.
In fact, I'll tell you a very
Just one point I would like to add. There are two different kind of tumors that we are talking about. One is buccal mucosa, which is inoperable. Another one is tongue.
Yeah.
So if there is a tumor which is on the base of the tongue going into anterior tongue, and we have bulk of the disease there, definitive CTIT has a role. But if it is buccal mucosa, even we have seen that if the patient has been deemed inoperable and we post NACT, patient is given CTRT or upfront CTRT, most of the things doesn't work because of the fact that ITF is the reason where it fails.
correct.
That is the reason that is the reason that is the site where neither chemotherapy works, neither radiotherapy works. It is a hypoxic region, and with gross involvement of the bony tumors, getting a complete response is nightmare.
In fact, there was a phase 1 study which we had written with Shantam when I was in TMH. It never took off. It was about chemosensitizing dose of radiation. So you give chemotherapy along with you give small doses of radiation, about 1 to 1.2 gray, which actually will sensitize further action of chemotherapy. So it was looking at, normally we give chemo to do radiosensitization. That was radiation given to chemosensitization. And the idea was that, okay, let's take help from radiation also in this. But the way this had to be given, it had to be given twice in a day, small doses. We are not been able to give hyperfractionation, which has survival benefit in head and neck cancers in multiple situations. Even if
Sir,
you would have made this regimen, it won't have been practical to use it.
Any difference in response to chemoradiotherapy radical in tongue versus non or other oral cavity other than
Yes,
tongue?
yes.
Tongue is better, I think.
You will always see oral cavity cancers, though we club everything together, the biology of a lip tumor, a buccal mucosa, a gingival-buccal complex, which according to me actually behaves very differently, a floor of mouth, which behaves very badly, hard palate goes like a maxilla, and tongue behaves differently. So all these 6 subset actually behave differently. I completely agree with him. Tongue, if you have like T4 inoperable, you would try to do definitive CTIT in that one situation. And in fact, there's a small series from Northern Western from Dr. Ezra Cohen of around limited patients, of around 30 patients, which shows that you can get modest 5-year outcome.
I did it in 2 patients, sir. They are both in CR 2 year. One patient is maintained on OMCT almost 1.5 year, 3 are all doing well.
Okay, so I'll just
So for tongue, it is for tongue.
give a quick point on maintenance OMCT. This study will get already has got accepted in Lancet and will be in public domain in 1 or 2 months. We did a randomized study of radical CTIT. Patient who underwent PR, one arm received OMCT for 18 months, one arm received observation. It did show that giving OMCT after radical CTIT was detrimental and actually led to a higher failure rates and lower survival.
I know, I know, sir.
So
But
I would just
this
advise
patient
a
was
word of
not in
caution
CR.
for this. Yeah.
2 were in
That's
CR,
fantastic.
so that was observation. This was not in CR. That's why I gave.
With that, we'll end the session. मिश्रा जी ने हाथ ऊपर कर दिया. ना मिश्रा जी ने हाँ बोल दिया यार. क्या कर रहे हो तुम? चलो बोल. Yeah. So post CTIT, if the patient is not resectable, it actually would come as a platinum refractory disease, and you start immunotherapy after that. That would be the way we will take it today. So with that, I thank all the panelists, I thank the audience, I thank the organizers for the extra time. Thank you.
So one announcement, if you are not spoken to hotel people, please check out your rooms before 12. If you are not taken permission from hotel reception.